Hello, my name's Laura Coates from the University of Oxford, and it's my pleasure to join you today to talk about what's new in psoriatic arthritis. I'm going to be talking through some of the highlights from the EULAR 2022 Congress. So the first study I wanted to mention is something that's definitely impacted on my practice and how I talk to patients in clinic about treatment options. So this is a study from the Netherlands called COMPLETE-PsA, which randomized patients either to have treatment with methotrexate alone, with a placebo, or methotrexate in combination with leflunomide. And they used quite high doses, up to 25 milligrams a week of methotrexate and 20 milligrams daily of leflunomide. And they looked for a primary outcome at week 16 on treatment and saw a significant benefit in terms of the change in PsA score, and also for the proportions of people who were achieving good outcomes. And I think that's something that really resonates for patients. So higher proportions of patients achieving low disease activity or minimal disease activity. And that was associated with slightly more treatment discontinuations in the combination group, mostly because of nausea or other stomach problems, and a few patients showing high liver function tests. But generally speaking, they did really confirm the benefit of combination DMARDs in psoriatic arthritis. And this, I think, is the first convincing study to do that. Also, thinking about conventional DMARDs, there was a really interesting study looking at gut microbiota. So looking at the microbiome and the good bacteria that live in your gut, and whether we can predict response to treatment. And this study was with methotrexate. So patients with a new onset of psoriatic arthritis, just under 30 of them had samples taken before methotrexate. And then they were divided into those who responded to methotrexate and those who didn't. And what they showed was that a higher bacterial diversity predicted a good response to methotrexate. And we think that's probably something specific to oral medication. So it may not be true of the biologics, because obviously they're not absorbed through the gut, but it may be true for some of our other oral medications. And then, as you'd perhaps expect, the way things have gone recently, we had a few key trials of biologic drugs in psoriatic arthritis. And we had a couple of studies looking at bimekizumab. So bimekizumab is another IL-17 antibody, but unlike secukinumab and ixekizumab, which block IL-17A, this blocks IL-17A and F. So there were two large trials of bimekizumab. The first one was for those who were biologic DMARD naive. And in this study, patients were randomized to bimekizumab, to placebo, or to adalimumab as a reference arm. So it wasn't powered as a head-to-head study, but there was a comparison group for adalimumab. And that showed very positive data for bimekizumab, met all of the primary and key secondary outcomes. The primary outcome was ACR 50, but they also showed superiority for PASI 90, as you'd perhaps expect with an IL-17 inhibitor, and for minimal disease activity, with MDA rates of 45% at week 16, which is really quite high compared to what we've seen in previous studies. The second study of bimekizumab was in patients who were TNF inadequate responders. They could have tried one or two previous TNF inhibitors, and they were randomized either to bimekizumab or placebo. And again, this study met its primary outcome, ACR 50, and also all of the secondary outcomes, including PASI 90 and MDA. And I think what was reassuring for us as clinicians is that the response rates seem to look very similar in the trial of TNF inadequate responders and in the study of those who were biologic naive. And obviously, often when we're choosing newer therapies, we're often using these as second or third line medications first, and we have a high unmet need in patients who have failed a previous biologic. So I think having such positive data in this harder to treat population is a really positive move for the field. We've also seen another IL-17 antibody tested at EULAR, and this is in a smaller phase 2 study, and it's a drug called izokibep. It's slightly different from the other IL-17 antibodies because it's a nanobody. It's a much smaller piece of immune tissue that still blocks IL-17A and has a high affinity for IL-17A. And in this small phase 2 study, again, they met their primary outcome of ACR 50 and also secondary outcomes of PsA and enthesitis outcomes. So we're seeing more and more drugs in the IL-17 space, and there are subtle differences between. It'll obviously be interesting to see how that plays out in the long term in some of the larger studies, and whether the difference of having a drug that blocks IL-17A and F, or a drug that's a nanobody or a different formulation, may give us different clinical outcomes. At the moment, I don't think we've got enough data to say whether that will affect the clinical response in patients. And then finally, I wanted to touch on one really interesting abstract from the tofacitinib data. So obviously, since the publication of the rheumatoid arthritis study with tofacitinib, there have been concerns about the safety of JAK inhibitors and warnings put on these drugs by a lot of the regulatory agencies. But this study was in rheumatoid arthritis before. We don't have any direct data in PsA. So what happened in this abstract at EULAR was patients that were included in the PsA trials and in the psoriasis trials of tofacitinib, which is over 4,000 patients, were studied to look at their outcomes for MACE, for cardiovascular outcomes, and for malignancy. And perhaps unsurprisingly, they found that the chance of a patient developing a MACE event was higher in patients who have had a history of cardiovascular disease. It was higher in those who had a higher cardiovascular disease risk score, and higher in those who had metabolic syndrome. And that seems quite logical. It seems like what we would expect, both in the PsA and the PsO groups. But the other thing that they showed is that the risk of developing malignancies also seemed to be higher in those who had metabolic syndrome or those who had a higher cardiovascular disease risk score. So it seems that we may be able to stratify patients at baseline, that if we think about cardiovascular disease risk and metabolic syndrome, that may be a good way to select patients for JAK inhibitors, or at least to discuss the risk of those medications with potential patients. So I think there's still more to do in this space, and there's still more studies to learn about the long-term and obviously infrequent but severe side effects that we have seen in the previous rheumatoid arthritis trial. But perhaps it helps to guide us as clinicians to think about which patients may be suitable for a JAK inhibitor and which patients we would be more cautious in using those. So thank you very much for joining me for this whistle-stop tour of the highlights of EULAR 2022.